a large audience, and I hope to tell you something about the relationship between volume and the golden standard, which is tissue perfusion, and the microcirculation. So let me just see if I can make things work. There we go. This is my declared interests. I developed some of the devices that I will be talking about and received money from industry, for which I'm very grateful, and I run a internet site regarding the microcirculation. So I'm a physiologist. I'm not a clinician. I'm not an intensivist. I'm going to say politically incorrect things. I'm going to say things that are going to make you feel uncomfortable. It's my role in this conference to do so. So please get angry with me, throw tomatoes and eggs. It will be all very fine. I'm used to it because I'm a physiologist. So let us look at some of the gurus of hemodynamics, and we have them here. They all agree that the physiological rationale when administering fluids in acute circuit dysfunction is to improve tissue perfusion. Everybody agrees with that. But when they discuss on how to achieve this, they all talk about blood pressure. Blood pressure, blood pressure, blood pressure, blood pressure. The only reason you use blood pressure is because pressure transducers are cheap. If you could measure flow, you would do that. So there's no real reason for measuring blood pressure, and this was a POCI, Perioperative Quality Initiative consensus, which has just appeared in the British Journal of Anesthesia, where we talked about blood pressure management and realizing that there is a real big fall in blood pressure to the tissues where everything is going, and that arterial blood pressure is just an input to the organ flow, but it's not the sole determinant of perfusion pressures. And we discussed many conditions in which manipulating the blood pressure really has no effect on microcirculatory tissue flow. So blood pressure does not equal flow in the tissues. Certainly, if you manipulate the blood pressure by constricting blood vessels because of Ohm's law. So we can look directly at red blood cell perfusion or flow by looking at the microcirculation underneath the tongue using devices like this, and we have presented much data regarding this particular technology. And one such application in hemodialysis patients really showing very elegantly that hypovolemia is associated with a reduction in perfusion of the tissues was done in this study already some time ago. So these, on the y-axis, you see the flow in the microcirculation measured sublingually. And here you see they're starting, these patients who are already normally is 3, you see that they have got low blood flow. If you do a passive leg raising, you can see the recruitment of the microcirculation. If you now start doing hemodialysis, you see hypovolemia going all the way down to almost 0 in some patients. If you then do a passive leg raising, you see an enormous response. This occurs in the smallest capillaries, less so in the larger vessels. A similar study was done just this week on anesthesiology, a fantastic study with Jacques Touranteau and Jean-Louis Thibault in perioperative setting in major abdominal surgery. And what they looked at were all the different hemodynamic indices giving a fluid challenge. And what they found was that there was no effect of fluid challenge on the blood pressure variables, such as mean arterial pressure or on heart rate, but there was a significant response for a fluid challenge on the pulse pressure variation, as talked about by my friend Xavier, and stroke volume index, but also in all the microcirculatory variables. So here we see in a setting where a patient is under vasodilation because of the anesthesia and has got a relatively normal physiology, a coherence between the macro and the microcirculation, but not blood pressure, which is a ridiculous parameter to look at. So if we now go to the ICU, we already have a bigger problem because the vascular regulation in situations of inflammation is altering autoregulation. And this very elegant study by my good friend Christian Burma and Andreas Krasnakus said, well, if we look at the clinical indications of organ hypoperfusion, such as tachycardia, impaired skin perfusion, oliguria, hyperlactemia, etc., is there a lack of tissue perfusion? And they found that there was a portion of the patients that had a lower perfusion, but others were completely normal. despite the presence of these surrogates of organ hyperperfusion, if they gave fluids, they saw that only the ones with the hypoperfusion responded and also reduced the surrogates of hyperperfusion, but that the ones that did not also did not reduce in their surrogates. So about 30 to 40% of these patients really had completely normal flow, but had these indicators and were given fluids for really no reason, and there was no relationship between stroke volume variation and the microcirculation. So now we get into the area of the disassociation of the microcirculation and macrocirculation. We call it microcirculatory shock. And this is one such review paper showing really that despite variations in the cardiac output, there's really no relationship between cardiac output and the flow in the microcirculation measured underneath the tongue. So we have called this particular concept hemodynamic coherence. So hemodynamic coherence is the idea, the expectation in resuscitation medicine, that when you correct the macrocirculation, that the tissue perfusion and the microcirculation follow. That is normal physiology. However, there are conditions when there is a loss of hemodynamic coherence, and this will cause you to give more vasopressors and more fluid, and it is potentially dangerous. There are 4 situations. You can have a heterogeneity in the microcirculation due to sepsis, for example. Hemodilution, you've diluted the microcirculation, you've used too many vasopressors, or you have increased the venous pressures too much, you get a tamponade or tissue edema. Now, all of these studies about fluids, again, in my opinion, this journal has been responsible for polluting the ideas concerning fluids. And actually, everything that's in this journal, in my opinion, is really fake news and should not be regarded. And this is Luciani Gattioni, my good friend. Physiology is the only polar star we have. And we have to look at mechanisms in order to understand what these fluids are actually doing. And the idea that the only fluid that you're using, which is poisonous, is starch and saline, is not true. They're all poison. And we know that from Paracelsus, who was a very wise man, the founder of toxicology. Let's look at your favorite fluids which you're using now. Albumin. Albumin has become a holy fluid. Albumin causes a lot of inflammation. But you have to look at the literature. IL-6, everything that you want to goes up with albumin and causes endothelial injury. And in clinical studies, propensity scoring in these post-cardiac surgery patients, dose-dependent acute kidney injury occurs when you use albumin. Ringer's lactate, it's even worse. Lactate causes sugar to occur via neoglycogenesis. Of all the fluids, it causes the most inflammation, even more than Hess does. And in this study, they actually showed that it causes rats to die earlier than Ringer's solution. Let's not talk about saline. I mean, saline is just a lot of salt, basically. And this is one of the latest studies that's showing. So, if we look at these New England Journal of Medicine studies, we see that they are using these solutions in conditions in which they should not be using. The chest trial was given to normal volemic patients. You do not give a colloid to normal volemic patients. Don't be surprised if your kidneys don't like it. Again, a lack of physiology in these trials. So it's all about the microcirculation, of course. So let's first ask the question, is when you administer fluids, where do they go? Well, this is a great study by Frost. It's telling you exactly where they go. And if you look at your crystalloids, which all of you are now using because you don't use colloids anymore, they don't go into the vessels, they go into the interstitial space. That's where they go. And what happens then? We did this study in cardiac surgery patients. We looked at the cardiac output, the microcirculation, and the interstitial water and intracellular water. And what you see is indeed the stroke volume goes up when you give these fluids, but you see that the microcirculations get diluted. Obviously, more water, less hemoglobin. You need the hemoglobin for the oxygen. So you're improving tissue perfusion by hemodiluting it and by reducing DO2. It does not make sense. And what you see is that the patients get a lot heavier, and all the, this is the bioimpedance data, all the fluids is accumulated in interstitial space, but it causes intracellular dehydration. So if you give crystalloids to patients, you are fluid overloading the interstitial space at the expense of intracellular water. And intracellular dehydration, as we already know from the last century, in a large number of studies done with radioactive labeled water, causes protein degradation. So that's what you were doing with crystalloid resuscitation. And also, this is a study done with Haiwu in Beijing, and we did a microcirculation studies on the lungs in dogs giving PEEP. So as you well know, if you give PEEP, the cardiac output goes down, and you might want to give fluids. If you do that, what happens is that the PEEP expands the alveoli, and the fluids start to accumulate in the septum. So all that crystalloids do is it gets you wet lungs and wet kidneys, both of which are really not wanted. So how can you reduce the amount of fluids that you're giving, because all fluids are poison? Well, you can give a colloid instead of a crystalloid. Here we see a study that we did doing exactly that. And if you look carefully, you can see on the right, in colloid priming in cardiac surgery patients, the distance between the red blood cells is larger. So they say, yes, but that's what's so bad about these colloids. You have to give more blood transfusions. Oh, of course, because that's what volume expansion does. You have less hemoglobin because you're expanding the volume. It has nothing to do with pharmacological aspects of colloids. It's just simple like that. And you can see that it much more effectively expanding the volume in the crystalloids. And these studies show that if the clinical problem that you want to solve is hypovolemia, then you must be certain that the fluids that you're giving remain in the vasculature. And the colloids, such as Hess, are the most effective ones. And the crystalloids, all they do is they just go and make wet tissues and reducing oxygen carrying capacity of your organs. So if you now choose a hemodynamic target, and that is key, to choose a hemodynamic target, then you get the benefits of using colloids over crystalloids, as shown in this study by my good friend Arnaldo Dubin. He used mean arterial pressure to normalize these patients, and he showed that he used a lot less colloids than crystalloids, causing blood vessels to get filled more and also causing higher flow. And we know from the crystal trial, which is a physiology-based trial in real patients that require hypovolemia resuscitation by giving colloids, that then you get the benefits of using a colloid and not like the Chester or the 6S trial. So what else can you do? You can use tissue perfusion as a target instead of blood pressure. This pig study did exactly that. It bled the pigs 1 liter of blood, used microcirculation as a target, and blood pressure as a target. To normalize blood pressure, it required almost 1 liter of fluids, including 300 milliliters of blood and 800 milliliters of venous lactate. For the microcirculation, only 170 mLs of venous lactate was enough. So the amount of volume that you're administering has nothing to do with the patient. It just depends on which number you're looking at to normalize. Finally, you can add a bit of vasopressors. And this is one of many studies. This is the one again from the group from Jacques Vivanto, showing that if you give fluid resuscitation with or without norepinephrine, you are able to resuscitate the microcirculation. Here, fluid resuscitation targeting 60 millimeters of mercury, there with a bit of norepinephrine. And here you can see the enormous difference in volume that you need to give again to reach the target. You must always have a target. And then, of course, you can de-escalate the patient by removing the fluids. And that is really a fantastic way of recruiting the microcirculation. This is a case study giving Lasix therapy in post-cardiac surgery patient. And this was on day 1 and day 3, the microcirculation in exactly the same spot. And you can see that after successful Lasix therapy, that here you see absence on day 1 of filled vessels that come back after day 3, reducing the diffusion distance between red blood cells and the cells and improving oxygen transport. My last couple of slides, Mr. Chairman, is what about inflammation and sepsis? Well, there you have a real problem. No fluid on Earth, with the exception of blood maybe, is going to cause this type of a microcirculation abnormality to be better. So we're talking really about red blood cells that are not working and endothelial cells that are not working. And if we look at ischemia reperfusion, you have the same thing. You are well able to improve cardiac output, even extracellular lung water. But if you look at the gut, you see that despite the fluid resuscitation, it is completely and totally ischemic. You have a total
loss of hemodynamic coherence in these conditions. And this is my last slide. This is a study which we did last year in critical care medicine. And what it basically shows, it's a contrast-enhanced ultrasound study, completely different, but we're able to, in the kidneys, be able to measure the time it takes for the blood to go from the artery to the microcirculation. And you can see this is shock in T1, endotoxic shock. We improve the blood pressure by fluid resuscitation. Cardiac output goes up, but as you can see, you're not able in this endotoxemia model to improve the lactate. So this is something that resembles a lot your patients. If we look at the transit time, it takes a lot longer. And if you look at the microcirculation here, you can see normal flow in the capillaries. You have to look carefully. And here you see plugged capillaries and the lack of recruitment of the microcirculation. So this is our wonderful team in which we do all this crazy research. And thank you very much for allowing me to end my talk.